Good morning. I'd like to share a few highlights from some research on perinatal influences on lifelong health, and I'll also introduce a new Center for Population Health Sciences that we're developing at McGovern Medical School. So the research I'll be highlighting was motivated by the high rate of preterm birth, which affects 10% of all US births and 11% worldwide. And because of some remarkable improvements in treatment of preterm birth, over 95% of preterm infants now survive into adulthood. So it's the first time in history that very large numbers of infants born preterm and all across the preterm gestational ages survive into adulthood. So this raises the question, what happens to these people in adulthood? We need to understand their long-term outcomes to support their long-term health. Also, pregnancy is a natural stress test that may reveal valuable information about future health in women. So what are the long-term health risks in women with preterm delivery or other adverse pregnancy outcomes? By understanding those outcomes, we can identify high-risk women earlier in life and intervene earlier to improve their long-term health. These questions can be really challenging to study in places that have very fragmented health care systems like the US, because it's often infeasible to track long-term outcomes over the decades of follow-up needed. My colleagues and I found an opportunity, however, to study this in Sweden, which collects national data on the entire population. And the entire population is essentially a cohort, which enables following these outcomes across the life course. We conducted a series of national cohort studies with over 4 million births and their 2.2 million mothers. And we linked national birth data with national outpatient and inpatient diagnosis data and death data. And we examined preterm birth as well as other adverse pregnancy outcomes in relation to various chronic disorders and mortality with up to 46 years of follow-up after delivery. Some of the key findings for offspring of preterm birth are shown here. These are adjusted hazard ratios and 95% confidence intervals for these outcomes listed here, mostly cardiometabolic outcomes, but as well as chronic kidney disease, sleep apnea, and all-cause mortality at ages 18 to 45, comparing people born preterm to those born full-term. And as you can see, people born preterm have increased risk of each of these outcomes in adulthood, with the hazard ratios ranging from about mostly 1.2 to 1.6. Just to be clear, these are risks in people who survived to age 18 without the respective outcomes. So these are risks that emerge decades, sometimes after preterm birth. We also found higher risk for earlier gestational ages shown by these orange markers, which are for those born extremely preterm, though with much wider confidence intervals, but there is a gradient in these long-term risks by earlier gestational ages. These findings were adjusted for various sociodemographic factors and perinatal factors that are shown there on the left, and also co-sibling analyses to control for unmeasured confounding in families gave similar results. This did not seem to appear due to genetic or early life environmental factors in families that might predispose to both preterm birth and these outcomes. As we did this work, we also wondered what happens to these people's mothers. And so we explored this, and some of the findings are shown here. These are adjusted hazard ratios for each of these cardiovascular outcomes, as well as all-cause mortality in women who delivered preterm compared to those who delivered full-term, with up to 43 years after delivery. And as you can see, they also experience higher risks of these outcomes with hazard ratios mostly from about 1.3 to 1.8. These risks actually persisted over 30 and 40 years after delivery. So even women who appear to be doing well still had these increased risks that would emerge among those who delivered preterm, sometimes decades after delivery. We also found higher risk for those who delivered at earlier gestational ages, which are shown by these orange markers for women who delivered extremely preterm. So again, we saw this gradient of higher long-term risks by shorter pregnancy duration. These findings also were adjusted as shown here by various sociodemographic and other maternal factors. And once again, in co-sibling analyses that controlled for unmeasured confounding, we found similar results. So it seemed independent of both measured covariates as well as unmeasured confounding that is possibly shared within families. As we did this work, we also were aware that preterm delivery is only one of several important adverse pregnancy events. And so we wanted to characterize more comprehensively the long-term risks after each of those. So some of those findings are summarized here. These are adjusted hazard ratios for ischemic heart disease, heart failure, stroke, chronic kidney disease, and all-cause mortality associated not only with preterm delivery, but small for gestational age delivery, preeclampsia, other hypertensive disorders of pregnancy, and gestational diabetes. Each of them adjusted for each other as well as other sociodemographic and maternal factors. And as you can see, actually, all 5 of these major adverse pregnancy events are associated with higher long-term risks in these women, with hazard ratios ranging from about 1.2 up to 4.0. And once again, these risks persisted even 30 or 40 years after delivery. So sometimes they emerge decades after delivery in these women. So this work showed that preterm birth offspring have higher long-term risks of various chronic disorders and mortality in adulthood, most risks in the 1.3 to 1.6 range, but higher for earlier gestational ages. Women with preterm delivery or other major adverse pregnancy outcomes also have higher long-term risks of cardiovascular diseases and mortality, even over 40 years later. And this appeared to be independent of other sociodemographic and perinatal factors, as well as unmeasured confounding and co-sibling analyses. These findings have important clinical implications. They show, first of all, that preterm birth is a chronic condition that needs lifelong clinical follow-up. All 5 major adverse pregnancy outcomes are also long-term independent risk factors for cardiovascular diseases and premature mortality in women. Clinical risk assessment should include birth and obstetric history, which ideally should be lifelong to identify high-risk people and counsel them and reduce their risk in a clinical setting. And hopefully this information can help facilitate earlier preventive actions and anticipatory screening and long-term clinical follow-up. By understanding these long-term risks, we can hopefully identify high-risk people earlier in life and intervene earlier to improve their long-term health. We are developing a new Center for Population Health Sciences in the Department of Family and Community Medicine at McGovern. One of the main goals is to leverage regional, national, and international data, including Texas data, to enable new population health research. We hope to develop new cross-school collaborations in population health. We're currently studying some of these topics I've just highlighted in maternal and child health, but also other areas, including mental health and high-risk populations, including, for example, cancer survivors and their partners, as well as cognitive aging and dementia. We're studying substance use outcomes and prevention, as well as other areas. We are still, didn't mean to pass that one, but we're still recruiting for epidemiology positions, and we would love to explore collaborations with any of you and would welcome your ideas and thoughts. I'll just acknowledge and thank the funders of this work at NHLBI, my Swedish colleagues, Christina Sundquist and Jan Sundquist. And thank you. I'd love to discuss this further and would welcome your ideas.